All right, we're going to change gears. We're going to get into, as we alluded to, more of a focus around oncology care. A lot's been said about oncology care with IDNs, and in particular, as a result of 340B. I shouldn't say as a result of purely 340B, but 340B and other market drivers, there's been a significant shift of site of care for cancer patients, where 80% of it 5 to 10 years ago, we'll give a range, was being provided in the community setting in private practice clinics, and half that number is today. And the half that's not there is being treated with site of care, usually in a facility owned by, again, an IDN, however we define it. There's been a lot of challenges to if that is improving quality, if it is it doing so, is it also increasing cost? And if it's not improving quality and increasing cost, what's been gained in that transition? And so understanding the role and opportunity for IDNs in cancer care, but the experience thus far, I think would be the place for us to start to level set to begin with. So why don't you take it away,
Sure.
Mark?
So I'm going to say something a little heretical, perhaps, as someone who works for a health system. But I am a big believer in site neutrality. I actually think it is unreasonable to pay hospital outpatient departments more for the services that they provide than a physician office. I think the value of the service is the value of the service. Our health system happened to actually make the decision to move our cancer center to a site where we now operate in the physician fee schedule, because we thought in a value-based world, we want to be less expensive, not more expensive. I think where the IDNs have an opportunity, and I'll also tell you that I know that U.S. Oncology is doing some interesting things and trying to diversify, and they're trying to have more multi-specialty type practices and networks. I think that's where IDNs have an opportunity in terms of improving outcomes and coordination of care. And also, if we're headed to bundles, if you don't have all of your specialists and all of your facilities lined up in some coordinated way where you can monitor costs, measure outcomes, and coordinate that care, you're not going to be able to participate. I think the OCM is just kind of the tip of the iceberg, because it isolates medical oncology, yet at the same time makes the medical oncologist responsible for a whole lot of stuff they have no control over. So obviously there's some flaw in the model, to say the least. But I think that's where the IDNs, now an IDN doesn't have to necessarily mean employment too. I mean, there are lots of different ways to integrate care. There are lots of different relationships one can enter into. But I think certainly in cancer care, it's where we have to go. And I think that the reimbursement models are going to push us there one way or the other.
So I'd say that's very aspirational, but it doesn't necessarily match with reality today. So your experience and where we are for the last 5 years of this experiment with the migration of community oncology into an IDN, often with the exact same site of service performing the exact same care at a much higher cost.
I've already said I hate hospitals, so we can just start with that.
That's the payer perspective.
No, actually, that was long before I was a payer. Yeah, I think, if you talk to most oncologists who practiced in the community.
Should I interrupt and say that the opinions of Mike regarding hospitals are Mike's alone and not representative of ADVI?
You can say that if you like.
You used to always give those preemptive statements.
I know. So I think the issue is this, right? So if you, coming from the perspective of a community oncologist who has witnessed the migration that you've pointed out over the last decade, let's say, I think there's a certain chip on the shoulder of most community oncologists regarding the unfairness of the current payment model, which is modestly unfair for government payers and profoundly unfair for commercial payers. There is fear that a lot of the proposed changes in oncology reimbursement that are on the table right now under the current administration could further make it difficult for providers for community providers to maintain their independence. I think independence is a very important thing for a lot of community oncologists. I think the idea that they would work for a hospital, have to answer to some hospital administrator, is just unfathomable. But the fact of the matter is, in the evolution of payment models towards responsibility for total cost of care, the pride associated with being independent and all that becomes almost unsustainable. I know of no community oncology practices, even Texas Oncology, that are in a position to negotiate a day rate for a bed. with a hospital. They just don't, they've never been forced to do that. They have no idea really where to start. And so I think it is inevitable that there has to be some relationship, I believe, between IDNs or hospital-based providers and community oncologists, because the community oncologists will not be able to survive without a relationship. Now, that's not going to be an employment relationship, I don't think. In fact, we'll see what happens. We may have reached the peak of hospital employment of oncologists, because when they shift from being a revenue center to a cost center, those meetings with the hospital administrator, they take on a whole different tone, whole different dialogue, right? So,
Yeah, and just the changes in 340B payments, I think that we will certainly see the stim in acquisitions, and you might even see that shift backwards.
Yeah. I mean, my concern would be that with regard to the 340B issue, that how dependent have the hospitals become? How much?
Very.
Right. And do they have an unbalanced balance sheet now because of that dependence? And how quickly can they recover?
Well, I come from a non-340B health system. We're not 340B, and we've been able to successfully develop and grow a program. To your point, Mike, I don't know if as infusion becomes less lucrative, whether there'll be a shift back to private practice. The other wild card in all this is the fact that when you look at trainees coming out, the millennials, many of them are not as entrepreneurial as we were when we came out of residency. A lot of them are not looking to go into private practice. They like the idea of working for an integrated delivery network or a health system.